Welcome to the new Kahoot review for the new RCIS questions in 2024. Many took it this year and just had some questions on some of the topics that they saw, so I just curated it into this mini Kahoot for you to kind of review and walk through. So what I'm going to do is I'm going to take it with you and kind of narrate how I would think about these questions as we walk through them. So let's dive on in. The first one, how many lumens in a monitoring swan? So some of the types of swans, monitoring TD, the thermodilution swan that you use to inject to take cardiac outputs, and then a VIP swan, which we don't see too much unless you're putting one in to take the patient to CCU. So the monitoring swan is the one that has two ports, okay, which you could call, I guess, 2 lumens. One is for the balloon port to inflate and deflate the balloon, and the other one is the distal port, which is where you would pull any of your saturations from. That's where the wire would go in, so it comes out the distal tip. So the answer is 2. How many ports in a thermodilution swan? So this one is interesting depending if it's termed ports or lumens. Even if it says lumens, I'm not even 100% sure if they're trying to include what I would call the plug or not. So you have the proximal and distal. Well, you have what the monitoring swan has, right? The balloon port and the distal port where the wire goes. That comes, well, you could also call it the PA port or PA lumen, that's the one that comes out the distal end. Then you have the proximal port or the injectate port. It's blue, where you inject the saline for your cardiac output. So that's already 3. And then you have a plug, okay? You have what I call the TD connector, and that's what connects to the monitoring system so that the thermistor can pick up that change in temperature and it can communicate with your monitoring system to show you that nice cardiac output curve. So the answer is probably 4, again, if we're including that plug. What can echo measure? Choose 2. Okay, so echocardiography, right? It is a non-invasive way of visualizing the heart. Remember what we're using it for. You can see fluid and the valves and the contraction and relaxation of the ventricles. You can also see shunts and regurg, right? Where you put on that color flow and it gives you that kind of mosaic color for regurg. So we can also measure velocities on there, because when a valve is stenotic, it'll have a higher velocity going through it because all of that fluid is going through a smaller hole, all that blood, we'll say. And we can measure pressure. So I know it's not like invasive monitoring like we do, because the patient sometimes still comes from a right heart cath, but you can see, if you've never looked before, now you will on the echo report, it will have like an estimated RV systolic pressure, for instance, and we'll look at that to kind of say, okay, do we think they have, pulmonary hypertension or not? Is that RV systolic a little high? How's the right heart doing? So we'll say velocity and pressure. Saturations, you have to physically pull blood out, which we can't do, right? That has to be invasive. And O2 concentration, kind of same thing here. That have to be a blood sample, which hopefully you're not taking from an echo outside the heart. The bright concentric circle on IVUS is the catheter. True or false? Okay, this one's hard because you could have an echo bright circle on IVUS, right? Or it's not concentric usually, but it can be 360 degrees around the vessel for sure. But that echo bright followed by the acoustic shadowing could be calcium, right? But that nice concentric circle, usually in the middle in the lumen, that would be helpful to have that terminology there, is the IVUS catheter. It's like that perfect circle. It isn't, even a concentric calcium isn't going to be, a perfect smooth circle. So I'll say, yeah, this is probably true, what they're trying to talk about. What is an appropriate way to explain the procedure to the patient? So without really looking at any of the answer choices first, the rule of thumb is layman's terms, right? We don't say medication names, we don't say equipment names, very, very general, everyday kind of street talk terms. So we're going to give you lidocaine in your groin. Well, lidocaine's a medication name, so we'll say no. We're going to take a look at your heart. Okay, heart is a general term. We're going to inject contrast dye into your coronaries. All right, well, we don't say the word dye, right? In the lab, we call it contrast. So even then, contrast is more kind of medication name, I guess. I mean, it's not like Visipake or something like that, but I'd say out of all of them, we're going to take a look at your heart as the most general. Arrange the steps in order. Balloon the lesion, stent, deploy the filter, wire the lesion. So I guess we're talking about embolic protection. So first you have to wire the lesion in order to get the filter down. And then we don't want to do anything invasive wise without the filter. So then we'll balloon, and then stent would be the last one. And then I guess if you had an extra step down here, retrieving the filter would be the last step. And 18 French arterial access can be closed with what? Okay, so Minx and angioceal are really 5-6 French, and then I think there's an angioceal VIP. I think that's up to 8 French. Don't quote me on it. I'd have to look it up. And then perclose, yes, so one single perclose you would do, which there's no context here, right? One single perclose you could do 6 French, and then I think, now I'm gonna look it up while I'm right here. I think over 6 French or over 8 French, you use 2. I mean, you can definitely close an 18 French. You would just have to use 2 percloses. And I'm gonna sneak into the new orientation manual because I know I'll put that in there. Okay, so angioceal 6 French, angioceal VIP goes up to 8 French. Where is, perclose or pro style. Arterial can do 5 to 21 French. This does say arterial. Greater than 8 French, you're gonna use 2 devices. So you can do it, but you're just gonna use 2 of the perclose or pro glide. If a TAVR valve is deployed too deep, so too deep would be towards the left ventricle or towards the LVOT, you should do what? So number one, your concern is the valve embolizing, getting pulled into the left ventricle from contraction and expansion. So that means it's not really anchored properly. So would you deploy a second valve, snare and remove, or leave it? Okay, well, I mean, you're leaving it in, but I mean, if it's deployed too deep, what they're looking for is a corrective action. Snare and remove, you would really only do that if it's embolized. You definitely have to take it out. But if it doesn't say it's embolized, it just says it's deployed too deep. So deploying a second valve to kind of tact it to the wall, and you deploy the second valve not in the same place, but overlapped and a little higher up to kind of keep it in place would be the best corrective action. Coronary IVUS goes over what? Okay, coronary IVUS goes over an 014 interventional wire. It doesn't matter what kind of wire. If this just said general IVUS, I'd hesitate. I'd assume when you're taking the boards, assume they're talking about coronary unless they specify peripheral, because there is a peripheral venous IVUS that goes over an 035 wire. So I'm gonna say 014 since it's coronary, and even if it didn't say it, I'd be assuming coronary because we're taking an RCIS exam. If the transducer is above the level it was zeroed, the pressure reading will increase, decrease, or not change. So what we're talking about is really, let's say you have a manifold in your hand. You're not really moving the transducer that's mounted on the side of the table, but if you have, the manifold in your hand, and some people have the transducer on the manifold, if it kind of moves up or down the fluidostatic axis where you zeroed it, what will happen to your really arterial pressure? Because it will change. So it's the opposite of what you think it is. So if it's above the level it was zeroed at, the pressure will decrease. And if it's moved below the pressure it was zeroed at, the pressure will increase. So here it's above, so it will decrease. What action is correct for vasovagal treatment? Okay, so what happens during vasovagal? Low blood pressure, low heart rate. So anything that would increase the heart rate or increase the blood pressure would be a good corrective action. So opening fluids is an attempt to increase your pressure, right? And then closing fluids, it doesn't immediately decrease your pressure, but it's definitely not increasing it. So I'm going to say open fluids to treat the blood pressure. What defines air kerma? Kerma, radiation material, kinetic energy released in matter, kinesthetic energy, radiation in material. So if you didn't know, KERMA actually, I mean, it's not exactly an acronym, but it's meant to be similar to the words that it kind of stands for. So kinetic energy, KE, released R in matter is the correct answer. What is wrong in this echo? Okay, so first of all, you kind of have to identify what you're looking at, right? So the heart is here, right? You can see the chambers. And then, yes, the heart is encapsulated in the pericardial space. But what you're looking at, you can see in the chambers are black, right? Because there's blood or fluid there. Now, outside of the heart, you see it's also black, which means there's blood or fluid there. And it's normal to have a little bit, but this is a lot. So this is actually a pericardial effusion, an effusion meaning that there is blood or fluid in that space, which ends up kind of compressing the heart because it's a single compartment. So you fill the compartment with blood, anything in it is kind of going to get pushed to the side. LV thrombus, there's no thrombus here. You can see the walls of the ventricle. PFO, no, you don't have a good view of the interatrial septum. Do have a good view of the IV septum, but this is a pericardial effusion. Sidewise, it's both right and left-sided. It is kind of surrounding the whole heart. You can have an effusion that's kind of more on one side. Obviously, it moves when you move the patient, but this one is a pericardial effusion. What is shown in this angiogram? Aortic dissection, aortic perforation, or regurg. Okay, so the catheter is in the aorta up here. The left ventricle is down here. This is an end hole catheter, first of all. And then this one shows the rest of the injection. And what you're looking at is there's a two-toned aorta here. So first of all, for aortic regurgitation, you'd be looking for this contrast to go back into the left ventricle. And I see the heart shadow, but I don't see contrast in the left ventricle. Aortic perforation, you'd have extravasation of this, which I don't see yet. So I'd say this is an aortic dissection because I see first of all, end hole catheter up in the aorta like that in this context is a good clue. But you do have this two-tone contrast. It's darker here and then it's lighter here, and that's because it's going behind the vessel layers instead of in the true lumen. What is another name for Ativan? Oh, I'm not good with meds. So this is one that especially branded generic names. So this is one I would definitely have on my cheat sheet. But diphenhydramine is Benadryl. Okay, Valium is diazepam. So Ativan must be lorazepam. Okay, what is another name for Valium? We just said that, and it is diazepam. So I'm probably going to say this wrong. Midazolam is Versed. Diltiazem is Cardizem. So we're going to say diazepam. So you have three processes. You have photochemical, photothermal, photokinetic in that order. CTK, I guess. Photochemical will break the molecular bonds, so it's kind of loosening what's there. Photothermal heat and has a heat component, so that is what kind of comes from the laser, and that leads to vaporization, small bubble formation, and some of the cellular level rupture. Then you have photokinetic, so all those little bubbles come together, and that's where you get that Pac-Man effect from the large bubble. So large bubbles created, and then it breaks down more of the tissue. So it goes photochemical, thermal, then kinetic, from smallest molecular component to the biggest. So photochemical is first, we got to break the bonds. Photothermal is next, that's heat, vaporization, bubble formation, so we'll say forms the vapor bubbles. And then photokinetic, or the mechanical effect. Photomechanical is another one you will hear. So that's the bigger one, right? So that's where we remove the cell debris. All of the following are relative contraindications for PCI, except what? Unsuitable coronary anatomy, I would say yes, because that could lead to poor placement. You can't stent normal to normal. You can't track where you need to. High risk coronary anatomy and closure would lead to death. That sounds more like a bigger contraindication, but sure, I guess maybe relative, because you could put an Impella, I guess, if you would call that high risk PCI. Inability to take antiplatelets. Yeah, I would say that's a relative contraindication. And then third degree heart block, that can more be an indication for doing, especially an RCA PCI. So let's say third degree. What catheter is this? Okay, so this one, when it's not a multi-purpose, okay, multi-purpose is kind of straight. So you're really between a TIG and a Jackie. Okay, so the main difference between a TIG and a Jackie is one kind of has a shelf in the back and then one has a curved tip. So this one particularly, I can say, is a TIG. So you kind of have this shelf in the back. A Jackie is going to have a little extra curve at the tip. Like, I guess you could remember that as, a T has flat and flat, and then a J has a curve at the end of the J. So a Jackie would have a curve at the end, and a TIG is flat and flat. Which of the following are complications related to a pericardial synthesis? Well, there's a lot of things that could happen, right? Stroke TIA, not really, because your access is not even really in a vessel, you're going into a space. Coronary artery laceration, absolutely, because you are external, right? And in the chest area, usually subxiphoid, you're sticking a needle in and passing wires and those sorts of things. So you're trying to pass the wire in the pericardial space, and coronary vessels are epicardial, so you are up against those. So you can cause coronary artery laceration. Chamber perforation, absolutely, for the same reason. You're poking a needle in there. You could perf the RV or the LV instead of trying to get into the pericardial space if you go too deep. And again, retroperitoneal bleed, same kind of thing with the stroke TIA. You're not intravascular, you're not in the vessel, and that's even then a retro bleed. You really kind of need to be down in the groin area. In this case, you're above the diaphragm, which is above the retroperitoneum. So choose two, say coronary artery and chamber perforation. Arrange the steps for an Allen's test. So an Allen's test is what you do to kind of check palmar arch patency. Now this one, some of these things are not really in this order, but let's just say these are the options that you get. So open and close the hand. Let's say occlude both, release the ulnar, and then release the radial, because what you're checking for is occlude radial and ulnar. If I release the ulnar, does it perfuse the other side of the hand where the radial would be if it was occluded? Because what you're simulating here is if we occlude the radial, will the hand still be perfused? What procedure is this? So this is the left atrial appendage, and you are putting something in the left atrial appendage that's occluding it. Okay, first of all, I spelled whatever that word is, ASD occluder, catheter directed thrombolysis. I mean, it is directed with a catheter, but it's not for the purpose of lysing clot. Left atrial appendage occlusion. This is a Watchman. What is shown in this 12 lead? Okay, is it complete heart block? No. I actually think they're an AFib if you look at the bottom of lead 2. Right, so right bundle branch block or left bundle branch block. So do you remember kind of how to look at this? So what I do is I look at V1 and I look at the isoelectric line, and if majority of the QRS is below, I think of turning when I push my blinker down, I'm going left, so that's a left bundle branch block. Initial choice when there is a rupture during an EVAR. So when someone asked me this question, I was like, what a weird question, because there's a lot to this besides just a simple answer. Because so an EVAR is like an endovascular repair of the aorta. So you could have a AAA, for instance, abdominal aortic aneurysm, and this is like a covered stent with pants kind of. So the waist of the pants is in the aorta, and then the legs are in the iliacs. So a rupture of the iliac and a rupture of the aorta, based on the two locations you're in, are two completely different things. So we'll say choose 2. Inflate balloon, reverse anticoagulation, covered stent. Again, like if you were in the iliacs, the covered stent is doable because the size. I don't know about, unless you're doing another EVAR, we don't really have covered stent sizes for the aorta. that are like, Viabons or whatever. Inflate a balloon, you could, again, iliac versus aorta are two different things, but you do use, this is a self-expanding stent. You do post-dilate with a balloon, so I guess you have a balloon on the table usually. Reverse anticoagulation, because it's an immediate bleed, yeah, that could be a resolution. So let's say inflate balloon, reverse anticoagulation. Well, maybe I should put covered stent, because if it's a rupture like in the iliac portion, or they're considering another EVAR as another covered stent, so I'll put all of them. No covered stent. Okay, fine. What does this angiogram show? Okay, so our catheter, pigtail, is in the aorta. There's a lot going on here, right? But the catheter is in the aorta, but I see the heart shadow out here, but I also see contrast in the left ventricle. So remember, we talked about this earlier. Could there be a little two-tone here? Yes. I do think this is more aortic dilation than dissection. Aortic stenosis, I can't really see, because you'd be evaluating that from the left ventricle and looking at contrast going out into the aorta versus the opposite. So I'm going to say aortic regurg. And that's it. So as you see, answers are not always black and white. You do have to do a little bit of research and kind of just try to decide based on the information that's currently available what answer you think they're getting at, what concept you think they're kind of trying to ask you about, and they are going to be confusing sometimes. And like you saw, like that EVAR one really got me, and I did a lot of research on that when someone asked me, and I'm like, oh, I don't really know, because there's a lot of different things to consider here, and unfortunately that's just something that doesn't have somewhere in a book you can look up that has the black and white answer. It is just a kind of critical thinking scenario. So I hope that helps, but if that sparked any questions, please put it in the comments or message me.